Hello and welcome to today's webinar, The Need for Change, the first in a series of webinars being presented by Lehigh Valley Health Network, Emergenuity, and T-System. These webinars will outline how Lehigh Valley successfully eliminated many complex problems, including overcrowding, low throughput, and improving patient satisfaction. My name is Amy Johnson, and in just a moment we'll be joined by our presenters. If you have any questions that you would like to submit for the Q&A at the end of the webinar, click on the icon with the question mark and type in your question at any point throughout the webinar. We'll gather these questions and try to address as many as time permits at the end of the session. If we don't get to your questions, we will follow up with an email to you one-on-one. We will have a recorded version of this session in the event that you want to go back and review the material, or if you want to share the presentation with a colleague who is unable to attend. I will distribute the recording of this event to all attendees. Leading our presentation today are Dr. Richard MacKenzie and Dr. David Richardson, practicing ED physicians from Lehigh Valley Health Network. Dr. Richard MacKenzie is an innovative physician executive experienced in turnaround and management of emergency and ambulatory medicine with multiple sites in university and community settings. He currently co-leads the steering team implementing a unique intake team model for emergency care delivery in the Lehigh Muhlenberg site. Dr. David Richardson has worked in the Lehigh Valley Health Network as an emergency physician since 1995. He is currently the Vice Chair Quality, Department of Emergency Medicine, and Chair of the Department of Emergency Medicine, PI/QA Committee. We also have a support panel who will assist in the QA at the conclusion of the webinar. Dr. John Weary and Chris Kidda, of Lehigh Valley, and Dr. Todd Warden of Emergenuity. Now to kick off our presentation, here's Dr. MacKenzie and Dr. Richardson.
Hello everyone, I just want to make sure you can hear us okay. And I'll take that as a yes. It's a pleasure to speak with you all, and let me introduce my colleague, Rick MacKenzie. Hi, Rick.
Hi there, and you ready to begin?
Yes, I am. The title for our first series in the 3 webinars is T-System, Change, Be Changed, or Wither Away. So, what we're talking about here in today's agenda, you can kind of see that we're talking about crowding, and we're going to talk about crowding and some solutions for crowding over the course of the entire webinar series. Today, we're really going to talk about why we have to change, why we have to move from where we are to where we're going to go. This is one of my favorite quotes, is that it's not the strongest species that survive, nor the most intelligent that survives. It is the one most adaptable to change. And I would submit to you, while Darwin spoke of evolution, I would submit to you that now we're under an evolutionary force in healthcare. The evolutionary force that we're experiencing is just as valid as a volcano or a meteor. And in fact, we have to evolve if we want to survive. There is a choice we have here. We can choose to evolve and survive, or we can choose to be extinct. We can choose dinosaur or mammal. That's our choice. And hopefully you'll see some of the evolutionary forces that we're experiencing today. So one of the biggest evolutionary forces that we're experiencing today is the crowding situation. And clearly, with crowding, we're seeing increased volume, increased length of stay, increased intensity of ED patient evaluation. I would like to know how many people are not feeling this in their emergency department. And in fact, I feel this every day in the emergency department. It is a bad feeling when all 3 of these things combine together to bog your flow. So, the good news with this is that you are not only not alone, but you also are validated by the data. The increasing volume is a fact. For the past 23 years, we have been increasing our volume in the emergency department. There were a couple years where we would kind of like stabilize a little bit, but for the most part, every year for the past 23 years, the volume nationally has increased. We also noted that this is not likely to change. This is an international concern, and HMOs in the experiment in the 1990s really had no effect on it. So we're now entering another experimental wave called healthcare reform.
one premonition we have of this healthcare reform is the Massachusetts experiment. Back in 2006, they mandated health insurance for all individuals that were employed. And in that 1 year, when they did this mandate, they actually saw an increase of 100,000 visits, 12% increase in the healthcare safety net in 1 year. So not only are we thinking the volume is going to increase, it could increase dramatically as healthcare reform is upon us. Now, there's also increased length of stay. The CDC, through the National Hospital Inventory Survey, actually found out that from 2003 to 2009, we actually increased our length of stay by 25%, and we got up to an hour in average length of wait. That's length of wait. And so now we move into the increased intensity. That's actually been supported just recently. In December 2012, in the Annals of Emergency Medicine, Steve Pitts wrote an article that basically points out the increased testing is occurring in our emergency departments across the nation. That is relatively new, and he equates that with the intensity. And in fact, when we talk about intensity, we talk about he even says in his conclusions that practice intensity is the principal factor for driving increasing occupancy levels. And I'll repeat that. Practice intensity is the principal factor for driving increasing occupancy levels. The one thing that he did not answer in the article was why. We don't know why the practice intensity has increased. There's lots of theory, but the truth is is what it is kind of thing. And we all are feeling this, and we're going to have to adjust. I don't think any of these trends will suddenly reverse themselves by magic. Dave, you can talk about how left without being seen and length of wait is affected by that.
Now, let me talk a little bit about lost revenue. And when patients wait longer to see a provider, you'll see an increase in left without being seen. And this doesn't meet your hospital's mission or serve your community, and you're going to lose revenue. So let's do an example here of a 40,000 visit emergency department that has the opportunity to reduce their left without being seen rate from 6 to 2% or a 4% drop. And in this ED, this example, that ED would see an extra 1,600 patients over the course of a year. And let's say 10% of those 1,600 patients are admitted. So that gives us 1,440 treat and release patients and 160 additional admissions. Now, on an average charge of $300 for each treat and release patient, the hospital realizes an additional $400,000 per year in additional charges. Now, for those 160 admissions, at an average of $8,000 per charge, or charge for that admission, that would be an additional $1.2 million in additional charges for the hospital. And when you add those two together, you get $1.65 million per year. So that's some definite cash there. So now let's take a look at diversion. Let's take that same 400,000 visit emergency department, and let's say you get an average of 1 ambulance per hour, and 40% of those patients are admitted. If that hospital is on diversion for 400 hours over the course of a year, you would lose 400 patients to your competitors. And at 40% admit rate, you would have 240 treat and release and 160 admissions. This would be lost charges of $1.35 million. Now, again, that's a lot of money. Now, all right, Rick, I can see your face. So here's the disclaimer. The charges depend on what your institution charges, and the reimbursement will change related to your payer mix and your contract. But, Rick, I stand firm on this. You will lose revenue when your patients go elsewhere.
And I understand that. That's millions of dollars that is being left on the table. And I like the graphic you had on that prior one. And I understand that as we get further, we're going to talk less about money and more about efficiency. But there's another money risk that's out there, and that's called liability. So we ask about liability. Is this really a factor? Most physicians almost don't think about this as a problem because they only think about it after they see the patient. That's when my liability starts. But that's wrong. In fact, your liability, and again, I make the distinction of liability and deniability. Liability is the chance you'll be brought into a lawsuit. and deniability is the chance you can win the lawsuit. So we're talking about liability here. An increased rating absolutely increased liability. In fact, Bob Bitterman recently quoted that this triage is the new hotbed of liability. And actually, when you look at the allegations in malpractice claims, you're starting to see failure to triage adequately and failure to reassess triagers as allegations in the case that get you into a lawsuit situation. So those are two very big things. At its root, though, is the patient has been waiting, and they're not happy with being waiting. And so that's where liability starts coming in. Unhappiness oftentimes drives liability. The other really scary fact here is EMTALA. EMTALA has a statute that we are required to do a medical screening exam on every patient that presents to the emergency department, leans into the emergency department, indicates they're possibly going to the emergency department. So EMTALA says the medical screening exam has to be done. It does not give a time frame on when that is. Some lawyers are beginning to successfully argue that an 8-hour length of stay, a 3-hour length of stay, sometimes a 24-hour length of stay does not meet the intent of the EMTALA statutes. So EMTALA violation, because you have a slow front door, is a really, really scary factor. Interestingly enough, Studer Group with the California Emergency Physicians did a study, unpublished study, but it has been reported in several venues, that basically they looked at patients that arrived within seen within 5 minutes compared to those patients that got seen in an hour. Now, please understand that when I say got seen in an hour, remember I just told you that the CDC's average wait was an hour. So now we're starting to talk, if you wait greater than an hour, and that applies a little difference, it's greater than an hour increases liability by a factor of 5. So 5-fold increase if that patient waits an hour versus 5 minutes. So this is a big deal from a malpractice standpoint. So now we move on. So, okay, it's malpractice. I don't care about malpractice. I'm a doctor. I'm a nurse. I'm all about patients. The reality is, if you want to cure disease, you got to get to it fast. The longer you wait, the more mortality you're going to have. And in fact, we do have anecdotes, at least, and people have heard these, of people dying in the waiting room. They waited too long. We had one recently in our area, not in our hospital, but in the Philadelphia community, we had one that was recently found dead in the waiting room. And these hit the national news. And also, on the other hand, that's not what we're about. We are about improving health of the community, improving health, and improving health doesn't let people die. And in the Annals of Emergency Medicine in 2012, we actually do have, now this is an abstract, but it basically says periods of high crowding were associated with increasing inpatient mortality. Now there's plenty of other literature that basically says mortality increases, whether you're talking about sepsis, MI, stroke. The mortality of a patient that waits too long will increase. In fact, one of the really embarrassing things that you see in the literature is that if you come in by ambulance with some of the major diseases of sepsis, stroke, MI, you're more likely to survive than if you arrive in our front door and actually take the effort to walk into our hospital. So you walk onto our campus, you're not going to be getting as good care as if you came in by ambulance, which is embarrassing. So it decreases quality of care. So on with the next piece, and now we're really trying to get you very depressed here. So we're not done. The depression will continue.
So Rick, liability is really a lagging indicator for poor performing ED. So what can you use as an early indicator? And really that's patient satisfaction. And as you know, satisfaction surveys have several sections related to arrival, nurses, doctors, testing, how your family was treated, etc. I believe that patient satisfaction goes hand in hand with ED length of stay and communication skill of your staff. Now, in the Press Ganey 2008 ED Pulse report, it was reported that the most important issue, rated by what Press Ganey calls a priority index, so the most important thing to patients was how well were you informed about delay. Now, this priority index reflects what items correlated highest with very high likelihood of recommended. So if patients were highly going to recommend your hospital highly, it means that they were informed about the delays. Both of those were correlated. So basically, patients want to know why they're waiting. Now, in the 2010 Press Ganey ED Pulse report, it noted that longer waits equal lower scores. Now, this can be mitigated by communicating with patients why they're waiting. But Rick, I'm telling you, it seems like added work for your staff. If they have to go around and tell patients why they're waiting in a busy emergency department, that's wasted time.
Satisfaction is satisfaction.
Yeah. So
that's what my docs say.
If you fix your inefficiencies and spend less time telling patients why they are waiting, you know, this seems logical to me. What do you think, Rick?
I do agree. I think that this is amazing, and this is somewhat obvious. If you're unhappy, all things follow from unhappiness.
So let's talk about how ED patient satisfaction affects inpatient satisfaction. So CMS uses the Hospital Consumer Assessment of Healthcare Providers and Systems, abbreviated HCAHPS, to measure patient satisfaction. And patient satisfaction is now part of the calculation for hospital compensation for these patients. Now, I assume your ERs are similar to ours, where it's the major thoroughfare for hospital admission. So patient experiences in the ER will affect their attitude and satisfaction with your inpatient stay. Now, if you Google HCAHPS in emergency department, you will find a FAQ from the Studer Group called the Emergency Department Front Door to Pay for Performance. And there is a graph that shows a linear relationship with the ED patient satisfaction percentile rank and the HCAHPS overall percentile rank. So what this means is lower ED scores correlate with lower HCAHPS scores. And so if lower ED scores are going to result in lower HCAHPS scores, and therefore you're going to have lower reimbursement for your hospital, or at least it's going to be a threat of lower reimbursement for your hospital. So ED patient satisfaction has wide-reaching effects. Now let me talk about pay for performance or no pay for performance, how you want to look at it, and talk about the core measures. Now the emergency department inpatient outpatient core measures are a blessing and a curse, sort of a double-edged sword, the yin and the yang, any way you want to look at this. But I may just be outside the norm here, but let's see if you agree. Most hospitals have ignored ED throughput as an issue for years. So diversion was an ED problem, not a hospital problem. So here's the good news. You know, here's the yin with the yang with these core measures. Hospital efficiency comes to the forefront. It's now a hospital problem, and performance is tied to hospital revenue. Now here's the bad news. The core measures also shine a light on the inefficiencies of the ED itself. So what we've done very well for a long time is treating those time to treatment dependent illness. So you remember your strokes, your MIs, your ischemic valve, all those are time to treatment critical. So we want to get those patients in the front door. And the Joint Commission and CMS recognize that ED quality is intertwined with speed and efficiency of treatment. I will argue that of all the ED inpatient, outpatient core measures, they are all time metrics. So core measures that include median time ED arrival to departure for admitted patients, observation patients, psychiatric patients, you know, those are all time metrics. My favorite is admit decision time to ED departure for that admitted patient. Because as you know, when you make the call as an emergency provider to the person who's going to admit the patient, there's a lag time between that phone call and when the admission order happens and that patient leaves the ED. So if half the time an admitted patient is spending in the ED is that time after decision to admit, you know, you really have to look at those processes for admission. Now, outpatient core measures are time metrics too. So if you look at DORT EKG for chest pain patients, median time to pain management for long bone fractures, those are all time metrics, and you have to get the patients in the front door to see a provider to perform highly on those metrics. Now, these metrics are reported on the Hospital Compare website. And if you haven't done this already, go to the website. It's www.medicare.gov/hospitalcompare. So one more time here, www.medicare.gov/hospitalcompare. Plug in your zip code or your hospital's name, and you can look and see and find some benchmarks for how you're doing compared to other hospitals in your state or throughout the nation. and it gives you an idea of what other people are doing and how you're doing.
I'm ready to jump. I'm ready to jump. I'm gonna end it all right now.
Rick, I just want to let you know this is just my representation of the Fiscal Cliff. Do you think it represents something else?
Yeah, I think that's the ED efficiency cliff. No matter where you turn, you're gonna fall. So I see you got some family pictures here.
Yeah, these are some of my favorites, Rick.
Now, that's Dave Richardson, for those people who don't know, the one with the bag on his head. So we're gonna transition over, and this is shameless self-promotion. We have 2 more webinars we're gonna talk about, but we're gonna talk about efficiency. So that's, if you really, this is the path going back. There is some hope. So the path to the future, the evolution that we have to do to get all those bad metrics heading in the right direction is return on productivity. We do not want to use the word return on investment, and there's a key reason for that. Investment, as we kind of like referred to, you start getting confused. There's lots of distractions there in terms of charges versus costs versus anything else. It's not a valid metric in healthcare, especially with multiple payors and providers. You don't have a set price for a product. It changes depending on the patient and the payor. So the one thing that cuts across all that is return on productivity. We need to improve how we make the things that cost money produce. And the things that cost money are probably twofold: your personnel and your space. So if you need your space to produce more money per square foot, that's a return on productivity. If you get your personnel to produce more service per individual, that's a return on productivity. So that's what I mean by efficiency. That's the metric for efficiency, return on productivity. And we're going to talk in the webinar about the 4 aspects here that we see in the emergency department queue, with one kind of like a little bit different from what you may have heard. Input, throughput, output, that's a common queue metrics. All queues have an input, throughput, output, and the emergency department is not isolated in it. It's not different from any of these things. It is a queue with input, throughput, output. The one key, and I think this is very pertinent to healthcare, is sustainability. We have to sustain whatever changes we have in input, throughput, output. And in fact, it's probably the holy grail. For some of us, it has been that we've been able to improve, and then within 6 months, we're back to square one. So we're going to have to talk about all that. So I'm going to take you through the plenty of bright ideas, and these are just very quick summaries of what we're going to talk about. And we're going to talk about input. These are some of the models that are out there, and we are using our own terms, and some terms we borrowed from other places. But essentially, bedside registration is when registration is done at the bedside. Pull to the full is where patients are put in the rooms. As long as their bed's available, they're brought back immediately to bed. Registration and triage are done at the bedside. Certainly, there's fast tracks or express cares where patients that have lesser illnesses actually go and get treated relatively fast. The thing called vertical flow is keeping patients that come in a seated position in a seated position. They remain vertical. The super track, that's where you try and do a small little area in the front of your emergency department to try and get rid of those patients that don't need much care and get them out really rapidly. And usually that involves a provider and nursing staff. And finally, what we call the rapid assessment unit, which is more of an intake team model that takes care of that nurse, physician, and provider that actually does treatment at the door. So next we talk about throughput. And throughput, there's certainly a lot of things that people have done, although probably this is where sustainability might play a role. Protocols, as in clinical protocols, to kind of be the standard work. And some people have implemented protocols as it's a quote from the Caribbean, Pirates of the Caribbean, as it's nearly a guideline. So it's really, you got to have more ironclad protocols to make throughput really exist. Diagnostic study turnaround time, that's CAT scan turnaround time. Do you have a results waiting area? Do you have a ST segment elevation MI process? Do you have a stroke process? Do you have case management in your emergency department? Do you have scribes for the physicians to take out the non-value added to the patient's perspective of that documentation? And do you have any situational awareness or dynamic variation that allows you to change gears as the situation or the demand changes, so you actually present a different model to the patient if the need appears? So we're talking about output. For output, there's bridging streamline orders, the pull to inpatient bed systems, where you move when the bed is assigned. There's patient floor coordinators. You have essential transporter dispatch. And are you even monitoring and managing the inpatient length of stay? There's a certain aspect, and I know certain institutions that the patient's length of stay is an integer. Basically, you either you drop one day, whether the first day or the last day. Different places just drop that charge for the day, and they do an integer charge. Should we really be doing one day and everybody gets stay, or should we really be monitoring and managing the inpatient length of stay in hours, like we do minutes for the emergency department? So this is kind of setting us up for the future. So we do have to sustain this, and that's the change management, people factor, PDCA. That's how we're going to have to sustain it. And we will talk about this in subsequent webinars and go into more detail as you hear this. Now, so I'm asking you from the standpoint, again, shameless self-promotion, if you think that we've delivered the message of change, then you owe it to your partners and your comrades and anybody else. Invite them into the webinars for the next 2 webinars and see if we can offer some solutions for you. So let me have you remember this. This is what we wanted to share with you today. Evolutionary forces, change is occurring, and I will point out you can change, and it's the evolution. You can increase your volume, not add staff, cut your staff to maintain margin, or you can actually change processes to achieve efficiency. Form always follows function, should always follow function. We do it the other way around, oftentimes in healthcare. And our webinar part 2 is scheduled for Thursday, January 31st, and you may register right from this screen. It's up there. So we're going to now move into questions, and here are our panelists. And they're all on the line. So, Anne, you can take it away right now.
Okay, we do have a couple of questions. Number 1 is, we're aware of the need for change. We're currently building a new ED. Should that fix the issue?
I'm going to ask Todd Wharton to answer that.
Yes, thanks, Rick. Yeah, one of the great misconceptions that we see, I think, from emergency physicians is that their crowding issues are due solely to lack of availability of space and beds. And I often hear when I go out, just give me more beds and I'll be fine. In fact, there's times that the ED needs more beds. However, the data that we have shows that space rarely solves the problem in and of itself. And if you don't integrate space, design, and the roles of the staff, you're not really going to get the leverage and meet all the patient's needs. And in fact, what you're doing oftentimes is bringing all of your broken processes forward that sabotages the end result of the new ED. And the worst thing a physician leader, can afford is after an institution has made this level of investment, to have it fail. So I would certainly recommend that people don't believe that a new ED in and of itself, without some major innovative changes in design and process, is going to be any more successful than old ED designs that provided additional space. Yeah, go ahead.
I'll actually add into that in the sense that new construction is an opportunity to change process. You just rock the people's world. You change where everything is. It's an opportunity to increase process, and that form follows function needs to play out. So you need to really play out your space. And actually, Chris, talk about how do you do the 3P kind of model. Chris Cheetah, Arlene.
Actually, in front of that, in some ways, new construction is actually
better for sustainability in that the new process is designed around the new construction, and then there's really no way to go back to the old way that easily. And then with the 3P model Rick mentioned, is actually, flowing form follows function, planning your process ahead, doing a mock-up preparation, and, we've seen organizations do this on an empty floor with cardboard cutouts of the room. But that's a good way to learn process before you actually start building new.
All right. Next question.
Okay. The next one is, I'm in a hospital that does not see the need for the ED to be transformed. How do we get senior management to recognize the need? They look at us as a cost center, not a profit center.
I'll turn it over to John Weary.
Yeah, I think it's important for hospitals to recognize that the ED is really becoming the window to the hospital, the front door to the hospital. When you look at an average or moderately sized department that sees 30,000 patients a year, when you add in family members and things like that, that's really the hospital's opportunity to contact those patients and the families and really give them a hospital, let them experience the hospital. So there's really no other practice or physician or department in any hospital system that encounters more patients than the emergency department. If that's not a compelling argument for change and for opportunity, I don't know what other case you can make. So this is something that I think many hospital leaders and administrators really have begun to embrace, that the emergency department is a venue for them to showcase and display all of the technology and efficiency and caring that the network or the organization has to offer. And putting the most efficient, finest processes in place with the best physicians and best nurses really is an opportunity to create that experience and get more patients to utilize a hospital organization.
I would offer two other suggestions. One that we did. One other suggestion is look at your budget and especially see if you're getting any credit for the admitted patients in terms of your profitability or your cost center. So you want to kind of at least point out what you're doing to the network in terms of your admission base. Most emergency departments admit 50% of the house, so it's usually a very big admitter. Second piece was that we actually did a study at our site to look at all the new players that arrive in our facility that never touched our hospital before, and that gave them the idea. In fact, it turns out we have a practice group here, a physician practice group, that the number of new players exceeded the number of new players of the entire physician group outside the emergency department. So it really points out that importance of capturing the market share. So that's one other aspect. Next question.
Well, right now those are all the questions we have, so if we want to give everybody a little bit so they can finish typing up their questions, or if they're still thinking of some questions. But in the meantime, I just wanted to let everybody know that I will be sending the recording and a copy of the slides to you guys tomorrow. So that way you can register for the Part 2, which is on the January 31st. So I've had a couple of questions on whether we're going to send the slides or not. So I will get those out to y'all tomorrow. And we'll just give a few more minutes to see if anybody has any other questions.
So we don't like dead air. I don't like dead air. And interrupt me when there's a question. So again, this is a task that I would hope we would embrace in healthcare reform. This is our task for healthcare reform, and we want to reform it in the right way. The experiment coming down the road in terms of the Accountable Care Act is going to happen, and we will have to deal with it. I think that it's important that we at least influence it in a way that patients are taken care of in an ethical way and not get forced into corners where we're trying to do things that may not be what's best for the patients because the money flows in different directions. Any other comments from anybody else?
Well,
I guess I just wanted to say that you know, a part of the the process of getting the administration to understand the importance of change oftentimes comes down to how you present the data and looking at the capacity of not only the number of patients that present in a given hour, but the total number of patients present in your emergency department, and helping them understand how to design and create processes that'll eliminate the waits in the waiting room and dramatically shorten the time to the patients being seen by the doctor and improving safety. So hopefully we'll get some folks back to listen to some of those issues that you guys have developed over the last couple of years.
Okay, we do have a question. What is the most important point when beginning the changes that must be done?
Great question. I'm going to Chris. He's better at it than I am. I'm usually telling people, let's change, and they run.
Well, there's two components to that. There's the physical part of it, the structure, the process, and then there's the people piece. And the people piece, by far, I think most important on the front end, is getting all the stakeholders in one place at one time, and talk about what is the goal, what are the objectives, what are the potential processes, or what you're thinking of in terms of how it's going to go, and getting all that input from stakeholders early on. We found that if you do that up front, it saves a lot of extra rework and time going back later and getting the buy-in from those stakeholders, from the registration end of it, from the nursing end of it, from the physician's end of it, from the APC end of it. It's getting everybody on the same page early in the process, including the CFO and the CEO. Get everybody involved in the discussion. And it's a lot of work trying to corral all those functions, but it's time well spent.
And I think the other thing is that to get people to the table, you have to have a leader that says there is going to be change. So you have to have a leader that says there is going to be change, and you can choose to participate or not. And people come to the table because they want to participate. And having them give input into the process is the winner. That's when you get the hook. So casting the line out is probably the leader saying you need to change, and then the hook is involving people, actually involving the people in the process. Do not do, this is what we're going to do, and I don't care what you say.
And just to add to that, this isn't, this is alignment right through the top, through the CFO, through the CEO, but it's that frontline engagement, that frontline staff engagement early on to help define, the big idea, the vision, and what it's going to look like and how it's going to work.
All right, Ian?
All right, well, I think that's all the questions for now. And if you guys think of anything and want to contact us, we will make sure to follow up with you guys later today. So we just want to say thank you so much for attending today's session. On behalf of Lehigh Valley Health Network, Emergenuity, and the T-System, we thank you so much for joining us, and we look forward to having you join us for part 2 of the webinar series on Thursday, January 31st. So thank you, guys.
Very much.
Thank you.
Thank you.
Bye-bye. Have a great day.
Bye-bye.